I did my project on irritable bowel disease. Patient is a 21-year-old female presenting to the clinic for evaluation of abdominal pain and diarrhea that had been ongoing for 2 years. She states that her symptoms recently became acutely worse after a recent breakup with her boyfriend. She reports intermittent lower abdominal cramping and bloating, as well as 4 to 6 episodes of loose stool per day for the last week. Patient notes that the pain is exacerbated by eating, seems to be associated with stress, and is relieved after having a bowel movement. Chief complaint is lower abdominal pain, primarily localized to right lower quadrant. Associated symptoms include diarrhea, bloating, fecal urgency, and mild nausea without vomiting. She denies recent weight loss or fevers. Patient endorses history of generalized anxiety disorder and depression. She denies illicit drug use. She admits to occasional alcohol consumption, noting that this has increased over the last 2 weeks due to stress. The only medication she takes is 100 milligrams of Zoloft daily for the last 5 years. Physical exam findings are a heart rate of 64, a respiratory rate of 20, a blood pressure of 118/64, and a temperature of 98.6 and 99% oxygen saturation on room air. She is alert and oriented ×4. She is in no acute distress, but walked into the clinic hunched over, clutching her lower abdomen. Her skin is warm, dry, and intact. Her pupils are equal, round, and reactive to light. Her extraocular movements are intact, and she has no scleral icterus. Her head is normocephalic and atraumatic. Her mucous membranes are pink and moist. Her neck is supple, and her trachea is midline. She has no focal neurological deficits. She has moderate tenderness to palpation to her right lower quadrant with no rebound, guarding, or rigidity. Bowel sounds are present throughout. Heart rate is regular and has with a regular rate and rhythm, with no murmurs, rubs, or gallops to auscultation. Her lungs are clear to auscultation bilaterally, and her respirations are even and non-labored. Her initial laboratory testing included a complete blood count, basic metabolic panel, CRP, SED rate, urinalysis, and fecal calprotein. Her significant findings are an elevated white blood cell count of 12.8, a CRP of 14, SED rate of 42, a fecal calprotein level of 450, ASCA positive, and PANCA negative, and her abdominal x-ray with barium revealed a string sign. This is her abdominal x-ray with barium. The white arrow in the photo is pointing to the string sign of the terminal ileum, which is due to narrowing. Inflammatory bowel disease is comprised of two major disorders, ulcerative colitis and Crohn's disease, which are characterized by chronic relapsing inflammation of the bowel. Ulcerative colitis primarily affects the colon and causes inflammation of the mucosal layer. Crohn's disease is characterized by transmural inflammation and can involve any portion of the luminal GI tract from the mouth all the way down to the perianal area. In ulcerative colitis, the site of origin of disease is the rectum, and in Crohn's disease, it's usually the terminal ileum. In ulcerative colitis, there's proximally contiguous involvement of exclusively the colon and pseudopolyps, and in Crohn's disease, there are skip lesions, cobblestoning mucosa, and aphthous deep linear ulcers anywhere along the GI tract, often sparing the rectum. Symptoms of ulcerative colitis are usually hematochezia, and in Crohn's disease, patients present with crampy abdominal pain. The thickness of inflammation in ulcerative colitis is through the mucosa and submucosa, and in Crohn's disease, it's transmural. Radiographic findings in ulcerative colitis include a lead pipe colon on X-ray, and in Crohn's disease, it can reveal a string sign on barium X-ray. Complications of ulcerative colitis include hemorrhage and toxic megacolon, and in Crohn's disease, complications include fistulas, abscesses, and obstruction. Surgical interventions in ulcerative colitis are curative, and in Crohn's disease, they're typically used for complications such as strictures. The risk of colon cancer in ulcerative colitis is markedly increased. and in Crohn's disease, it's only slightly increased. The pathology in ulcerative colitis includes crypt abscesses, which are common. In Crohn's disease, crypt abscesses are uncommon, but patients can have granulomas and submucosal fibrosis and fissures. Serology in ulcerative colitis typically reveals PANCA positive, and in Crohn's disease, usually ASCA is positive. Based on the localization of pain to the right lower quadrant involving the overlying the terminal ileum, string sign on abdominal x-ray, and positive ASCA on serology, the patient's likely diagnosis is Crohn's disease, one of the conditions that is classified as irritable bowel disease. To confirm this diagnosis, the patient will need to follow up with gastroenterology and to undergo an MRE or ileocolonoscopy. Endoscopic features of Crohn's disease are skip areas of involvement with segments of normal appearing bowel interrupted by large areas of disease. The rectal mucosa typically appears normal. During the colonoscopy, biopsies should be obtained from the right colon, left colon, and rectum to assess for histologic evidence of inflammation, such as focal ulcerations and granulomas, which are noted in up to 30% of patients with Crohn's disease. MRI with enterography also have a greater than 90% sensitivity for detecting inflammation associated with Crohn's disease and can reveal increased bowel wall enhancement and wall thickness, hyperintensity, possibly reflecting edema, and mucosal lesions such as ulcers. Clinical trials of Crohn's disease often use a formal grading system, Crohn's disease severity index, to describe disease activity and assess severity in order to determine appropriate treatment. The American Gastroenterological Association also recommends stratification of patients into either a low or moderate/high risk category by assessing inflammatory status based on the following tests. Endoscopic evaluation for mucosal ulceration, stricturing, and disease extent, laboratory parameters including CRP and/or fecal calprotein, and presence or absence of upper GI involvement. Patients with mild Crohn's disease or have no or mild symptoms and lack signs of systemic inflammation. They are at low risk for long-term sequelae. Patients in clinical remission are often asymptomatic. Patients requiring glucocorticoids to remain asymptomatic are not considered to be in remission and are referred to as being steroid dependent. In mild Crohn's disease, patients are typically ambulatory, tolerating an oral diet, and have less than 10% weight loss with no symptoms of systemic disease such as fever, tachycardia, abdominal tenderness, and signs or symptoms of obstruction. In moderate to severe Crohn's disease, patients have failed treatment for mild to moderate disease or have prominent symptoms such as fever, weight loss, abdominal pain and tenderness, intermittent nausea or vomiting, and anemia. In severe disease, patients have persistent symptoms despite glucocorticoids or biologic agents, or have high fever, persistent vomiting, intestinal obstruction, peritoneal signs, cachexia, or evidence of an abscess. The choice of treatment depends on the anatomic location of disease, severity, and whether the treatment goal is to induce remission or maintain remission. Pharmacologic treatment includes oral 5-aminosalicylates such as sulfasalazine and mesalamine, glucocorticoids such as prednisone and budesonide, immunomodulators such as azathioprine and 6-mercaptopurine. Biologic therapies include infliximab, adalimumab, certolizumab, and natalizumab. Low-risk patients with mild Crohn's disease receive the following treatment regimens. Step-up therapy typically starts with less potent meds that have fewer side effects, and more potent and potentially more toxic medications are used only if initial therapies are ineffective. Top-down therapy starts with more potent therapies such as biologic therapy and/or immunomodulator therapy relatively early in the course of the disease before patients become glucocorticoid dependent or before they even receive glucocorticoids altogether. Step-up therapy is preferable because it spares low-risk patients from the adverse effects of drugs that they might not need. The goal of treatment is to achieve endoscopic, histologic, and clinical remission by demonstrating complete mucosal healing. 5-aminosalicylates are the first-line therapy for mild to moderate Crohn's disease. The use of 5-ASA is usually limited to patients with mild Crohn's disease with limited ileocolonic involvement who prefer to avoid glucocorticoids. The mechanism of action is an anti-inflammatory with several different mechanism of actions that have been proposed, including inhibition of cytokine, prostaglandin, and leukotriene synthesis, free radical scavenging, immunosuppressive activity, and impairment of white cell adhesion and function. They can be administered as an oral dosage form, enema, or suppository based on location and severity of intestinal inflammation. The oral medications in this class include sulfasalazine, mesalamine, osalazine, and valsalazide. Sulfasalazine is a prodrug composed of 5-ASA linked to sulfapyridine through an azo bond. It's partially absorbed in the jejunum, and the remainder passes into the colon, where it is reduced by coliform bacterial enzyme azoreductase to sulfapyridine and 5-ASA. 5-ASA is poorly absorbed in the colon and is largely excreted into the stool. Sulfapyridine is rapidly absorbed in the colon, metabolized by the liver, and excreted in the urine with only small amounts excreted in the stool. 5-ASA is responsible for the efficacy of sulfasalazine, and sulfapyridine causes many of the side effects. Some considerations. It can cause significant GI intolerance if taken alone and should be administered with food. It should be avoided in patients with a sulfa allergy. It requires monitoring of renal function, complete blood count, and liver tests every 6 to 12 months. It can cause reversible male infertility due to reduced sperm production. It inhibits folate absorption, and 2 milligrams of folic acid supplementation should be taken if pregnant. Other adverse effects include hemolytic anemia, agranulocytosis, and rarely hepatitis, pneumonitis, or myocarditis. Mesalamine is an unconjugated 5-ASA that does not have the side effects associated with sulfapyridine, but it is just as effective as sulfasalazine. It's rapidly absorbed in the jejunum, allowing only 20% to reach the terminal ileum and colon. Delayed and controlled release mesalamine formulations consist of a single 5-ASA molecule enclosed with an enteric coat or a semi-permeable membrane that resists gastric breakdown, thereby increasing bioavailability in the small bowel and colon. In delayed release formulations, the release of 5-ASA is pH dependent. The acrylic-based resin dissolves at a pH of greater than 7, which allows for the delivery of 10 to 15% of 5-ASA to the terminal ileum and the remainder into the colon. It can be administered orally 1 to 3 times a day. In the controlled release formulations, the release of 5-ASA is time-dependent and not affected by the pH. The ethyl cellulose coating serves as a semi-permeable membrane that releases 30 to 40% of 5-ASA in the duodenum and continues to release it throughout the small intestine and colon. It can be administered orally 4 times a day, but some studies suggest that some formulations can be taken once daily. Corticosteroids. Used for acute flare-ups of disease when 5-ASAs are inadequate. For severe disease, we typically use hydrocortisone or methylprednisolone. These medications can be given intravenously during hospitalization for an exacerbation. The preferred agent of these two is methylprednisolone, 60 milligrams intravenously daily if there are no contraindications such as bowel-related infection. For moderate to severe disease, we typically use oral prednisone or prednisolone. In patients with active mucosal inflammation, prednisone can be initiated at a dose of 40 milligrams daily with a 10 milligram or 5 milligram taper on a weekly basis for a total of 4 to 8 weeks of therapy. This often results in rapid improvement. For mild disease, we can use budesonide. It's an enteric-coated medication and designed for the release in the ileum and cecum. It's reserved for low-risk patients with Crohn's disease. Budesonide is recommended as a first-line treatment for inducing remission in low-risk patients with mildly active Crohn's disease of the ileum and proximal colon. It is a glucocorticoid that is metabolized in the liver via cytochrome P450 isoenzyme. It has controlled ileal release. Budesonide has high first-pass hepatic metabolism, which reduces the systemic bioavailability of the drug. It started at 9 milligrams per day for at least 4 weeks, but for not more than 8 weeks. It is then tapered by 3 milligram increments every 2 to 4 weeks for a total of 8 to 12 weeks of therapy. It has an overall good safety profile, and systemic effects such as adrenal suppression and decreased bone mass are less common than conventional glucocorticoids such as prednisone due to the location-specific delivery and high first-pass metabolism. It's considered low risk in pregnancy. Disease activity and response to therapy is assessed clinically by observing a change in symptoms as well as obtaining serum and stool markers of inflammation, such as C-reactive protein or fecal calprotein. Once remission is achieved and budesonide is tapered or stopped, maintenance therapy can be initiated. The goal of tapering is to use a rate of change in dosing that will allow for observation of the early signs of a disease flare. Immunomodulators can be used for patients who have achieved clinical remission with glucocorticoids or for patients who are no longer responding to biologic agents. Azathioprine and its metabolite 6-mercaptopurine inhibit T-cell function and may induce T-cell apoptosis. Cyclosporine can be given intravenously to induce rapid remission, but it's a toxic compound that can cause renal impairment, neurotoxicity, and immunosuppression. Methotrexate can be used to promote short-term remission. Azathioprine and 6-mercaptopurine are thiopurines that are effective long-term, reduce corticosteroid requirements, and can maintain remission for years. Thiopurine methyltransferase, TPMT, genotype testing prior to initiating therapy with AZA or 6-MP is recommended. It can be initiated at a dose of 50 milligrams per day or at the full dose if TPMT genotype is normal. The dose of 6-MP can be increased to a maximum of 2 milligrams per kilogram per day, and AZA can be increased to 2.5 milligrams per kilogram per day if laboratory monitoring does not suggest bone marrow depression. Dose of AZA or 6-MP should be reduced by 50% and adjusted accordingly based on clinical response and hematologic response. AZA has delayed onset of effects up to 6 months and should not be used to induce rapid remission. It often requires concomitant glucocorticoid therapy with a gradual reduction in dose starting after 1 to 2 months of thiopurine treatment. These medications require regular monitoring for toxicity. Anti-TNF agents. 3 anti-tumor necrosis factor therapies are approved for the treatment of Crohn's disease in adults: infliximab, adalimumab, and certolizumab pegol. Infliximab and adalimumab are preferred for induction of remission, while all 3 anti-TNF agents can be used to maintain remission. Infliximab is a chimeric IgG1 monoclonal antibody against tumor necrosis factor alpha, comprised of 75% human and 25% murine sequences. Has a high specificity for and affinity to tumor necrosis factor alpha. It's indicated for moderate to severe Crohn's disease and has been shown to reduce the likelihood of failing induction of remission at a minimum of 12 weeks. It can be given intravenously every 8 weeks. It increases the risk of infection and infusion reactions, including chills, fever, itching, and dyspnea. Antibiotics can sometimes be helpful in Crohn's disease as well. Many experts recommend a combination of metronidazole and ciprofloxacin. 500 to 750 milligrams of metronidazole albendazole orally 3 times a day for 4 to 8 weeks may control mild Crohn's disease and help heal fistulas. 500 to 750 milligrams of ciprofloxacin orally 2 times a day may be less toxic. Rifaximin can also be beneficial in the treatment of active Crohn's disease and can be given at a dose of 200 milligrams orally 3 times a day or 800 milligrams orally 2 times a day. Antidiarrheal drugs. Not all diarrhea requires treatment, and complete cessation of diarrhea can be harmful if it is infectious in nature. Loperamide is the most common drug therapy used for diarrhea. We can also use absorbents and anti-secretory agents such as adapalgite, bismuth subsalicylate, and polycarbonyl. Loperamide. The mechanism of action is that it inhibits acetylcholine release through presynaptic opioid receptors in the enteric system, delays colonic transit, and increases gut capacity in order to enhance absorption. It decreases fecal volume, increases viscosity of stool, and increases anal sphincter tone. It reduces urgency, cramping, and stool frequency. It's usually effective within 2 to 3 hours. Limitations include addiction potential and worsening of infectious diarrhea. Dosing is 4 milligrams for one dose, then 2 milligrams after each stool, with a maximum daily dose of 16 milligrams per day. It has poor penetration into the brain. It should be avoided in patients with ulcerative colitis and aids with new abdominal distension due to increased risk of toxic megacolon. This patient likely has new onset mild to moderate Crohn's disease due to clinical presentation, laboratory results, and abdominal X-ray findings. Diagnosis will require a gastrointestinal consult and further confirmatory testing, including an endoscopy or MRE. Once diagnosis is confirmed, therapy should be started using the step-up approach, consisting of less potent medications with fewer side effects. 5-aminosalicylate is the first-line treatment for mild to moderate Crohn's disease. Patients should be started on either sulfasalazine or mesalamine, depending on disease location, patient preference, cost, and availability of drugs. If this proves to be inadequate in managing symptoms, patient could be started on a glucocorticoid such as oral prednisone or budesonide. A stool sample could be obtained to assess for infectious pathology. If this is negative and diarrhea persists, patient could be started on loperamide for symptom management. Summary. Inflammatory bowel disease is a group of disorders characterized by chronic inflammation of the digestive tract, including ulcerative colitis and Crohn's disease. Crohn's disease is a type of inflammatory bowel disease that can affect any part of the digestive system from the mouth to the anus. Ulcerative colitis causes inflammation of the colon's mucosal layer. The choice of treatment depends on the location of disease, its severity, and the treatment goal, whether it is to induce or maintain remission. And these are my references. Thank you.